It's a good question. And so, of course, the approach is always individualized, meaning that no two patients are alike. But in general, you want to consider using beta blockers in both POTS and migraine because this medication class is actually very good for both tachycardia and headache prevention. And also, it's very important to control underlying mast cell hyperactivity if that's what's going on. Ironically, some research in migraine headaches points to mast cell hyperactivity as a possible underlying pathophysiology of migraine itself, especially as it ties into neuroinflammation. It's a very important question. So what are non-epileptic seizures? And first of all, it's important to rule out syncope. Syncope are not seizures. It's basically fainting. And you can have anoxic seizures, meaning the problem is lack of blood flow to the brain that can generate some convulsive activity when you're unconscious. So number one, when you don't have epilepsy, do you have fainting that can be associated with a couple of jerks and what may look like seizure activity when in fact is not seizures as we define it in epilepsy. Now, the issue comes when it's not syncope, it's not anoxic seizures, and it's not seizures epilepsy. Then what? So if there is a suspicion for functional neurologic disorders, which is where we now label this non-epileptic seizures, the answer is no. There is no association between functional neurologic disorders and POTS. I think that's very important. When we have a patient that may have both conditions, then we have to deal with that. But as far as science is concerned, there is no evidence that these two conditions are linked. Yeah, those are great questions. First of all, clinically, I have not seen a problem with Botox in our patients. But of course, as I said, everything is individualized. So if you happen to have a reaction, some kind of reaction after Botox, the next step is to determine what type of reaction was it. If it wasn't in the first, I would say 15, 20 minutes while you're getting the injection, then it would be safer to say that these were non-allergic or non-IgE mediated reactions that are common in MCAS population. So maybe you want to avoid that particular brand. Remember that a lot of people with MCAS don't react to the active ingredient. A lot of people react to excipients, preservatives, and dyes. So the next time, if you want to try Botox, you probably want to pre-treat yourself with antihistamines and maybe have a portion of the dose, I don't know, 20%, 30% of Botox given to you at that session to see how you do. So Botox in general, I have not seen any big problems with that. Now, Botox for migraine is different than Botox for, let's say, spasticity or neck pain. And what about the craniocervical instability? You know, those are big topics that have not been researched. So usually Botox for migraine is injected in the face and not necessarily in the neck. And so if you're concerned, if you're someone with CCI, you might not want to choose injections into the cervical area. You may want to keep it, you know, in the frontal or temporal or you know, don't go to those areas. So I think, again, it requires working with your doctor and a very much personalized and tailored approach to each individual situation. Well, there is an increased risk of a slight increase in stroke in patients with any migraine aura compared to migraine without aura, compared to general population. So as I will often mention, there are no good studies on patients with EDS. And that's a big problem because we don't know how things are in our particular patient population. But we know from studies on general population that if you happen to have hemiplegic migraine, or if you have migraine with visual aura or sensory aura or motor aura, you have a slightly higher risk of stroke. Now, when you put this in absolute terms, the risk of stroke is still very small, especially if you're a young person, because the risk of stroke goes up for everyone as you age. But it is slightly higher. And on that note, you want to work with your neurologist to assess the risks of stroke and adverse events from other things like, for example, oral contraception, hormones, because they too increase the risk of stroke slightly. So I am always cautious. And if you have a lot of migraine with aura, I tend not to put you and not recommend hormonal supplementation in order to not increase this risk of stroke even higher. Right, that's a very common scenario and something I'm always trying to include when we talk about POTS to other doctors or in the articles, because what we don't want to happen is when you come to a tilt table test or your cardiologist and it doesn't show POTS, they say, oh, you don't have POTS, that's not it. Right, so you may not have qualified for a diagnosis of POTS by the diagnostic criteria, and you may not have qualified for orthostatic hypotension by diagnostic criteria. And yet here you are still having fluctuating blood pressure, heart rate, and having, palpitations and all other symptoms typical of autonomic disorders. So I call it autonomic dysfunction. I call it dysautonomia, though some of my colleagues do not like this term, and I'm not a big fan myself. But with COVID, you hear a lot of post-COVID dysautonomia terminology. And so, we might as well acknowledge that there is some kind of, problem with the autonomic nervous system, but you're just not meeting precise criteria. And that ties into the fact that we need to develop better tests, better biomarkers, better diagnostic labels in order to encompass all patients with autonomic problems. I see patients that are overrepresented among my patients with a history of cyclic vomiting syndrome. And so, cyclic vomiting syndrome is associated with migraine headaches in general. Is there research? Are there data on that? No, there aren't any data on that in POTS or EDS. And I keep saying that this is a very much untapped field. So if anyone wants to do research, if you're a PhD or MD student and you're interested in research topics, take your picks. There are so many. What I will say is that POTS and dysautonomia in general have shared pathophysiology with migraine headaches and shared pathophysiology probably with cyclic vomiting syndrome. And maybe there is some kind of genetic predisposition too, because cyclic vomiting syndrome is rooted in channelopathy. And so, again, we can go very deep and the outcome is going to be that we just need more research of these problems on specifically patients with EDS or POTS or both. So this is not prevalent. And if you have some kind of atrophy, whether it's decreased white matter or cortical atrophy, and you're a young person with POTS and EDS, understand that you should see your neurologist and to kind of move with the causes of this. Because again, as far as we know, neither POTS nor EDS should cause these problems in the brain. So your neurologist will probably have to look further. Is there anything else going on? Do you have a demyelinating disease? Do you have an autoimmune disease? Do you have a vasculitic kind of disease? So those are other questions because rightfully so, you ask, well, can we chalk everything up to EDS and dysautonomia? And my answer is absolutely not. Please don't do that. And especially on questions of neurology and neuroimaging, you want to see a regular neurologist and ask about all other 10 million neurologic disorders that can cause these findings. Well, it's a big problem because neurologic manifestations of EDS are numerous, but it's a very much evolving field. So I, along with several of my colleagues, are trying to, work on this very question and educate our colleagues in neurology of what they should be thinking and doing. And the first part that they should be thinking is actually identifying these patients among their multitude of, for example, chronic migraine patients. So how do we find them? Unfortunately, there are very few and far in between. But your neurologist can learn about these disorders by going to society web pages, by reading our articles, and by reaching out to the few of us who understand this. Like I said, this is a very much new and evolving field, and we're trying to kind of break through. Neurologists are a very conservative bunch and are difficult to learn new information, but there is certainly going to be a huge need for them to do so, not only with EDS, but also with long COVID and how everything ties into it.